So I'm a pulmonary critical care doc. My focus is in clinical medicine. What I want to talk today about is a little bit on sleep health and common sleep disorders that we run into. I give a lot of the lectures to the residents and at times students about sleep, and we go over a lot of technical factors and diagnostic criteria and look at some studies. I'm going to show a couple of those slides just because I think it's interesting to see what happens when we sleep to illustrate that. But really, I want to spend less time kind of talking at you and showing slides and maybe fielding some questions. Every day in clinic I learn something new, and patients come in with what's just been published, so I have to be on my toes at all times. About what I say and have to be abreast of knowledge that's out there. I have no financial disclosures. I did want to give a little bit of my background. I'm not only a sleep physician, I'm a pulmonary critical care physician, so I also do intensive care unit medicine. So I also take overnight calls still as an attending physician. However many years now out of medical school and residency, we still cover the ICU, where I go in at 5 p.m. and take care of anything that happens, and I'm done in the morning. I also have 3 children, the youngest of which is about 2 months old. They're all under 5. So I value sleep. And I know what it's like not to get enough sleep. And trust me, I really understand and can empathize with people who are suffering from sleep disorders and sleep deprivation. On that note, I want to take a moment to properly appreciate the experience of young mothers. I don't think that's a trivial issue. Motherhood is extremely challenging in a profoundly sleep-depriving state. There are not enough support systems for young mothers, especially the ones who work. That's my soapbox statement for the day. We'll move on. All right. My agenda is I'll talk a little bit about healthy sleep and sleep physiology. Then I'll focus on sleep disorders, really what we tend to see in the office. And I think that's probably the area where we can discuss a bit more. I mentioned here also insomnia and circadian rhythm disorders, of which the most common thing we probably deal with is shift work. Very familiar with that. And then at the end, we can kind of talk about ways to improve sleep and treat sleep disorders when it's time to actually go see someone and maybe have some sort of diagnostic test performed. Again, I just want to say thank you for allowing me to be here. I should also, since I'm here at UCLA, which is one of the great academic centers for sleep research, I don't want to gloss over that. Alan Reckschaffen and Anthony Kales were here and developed, when they were here, the scoring system for sleep stages. Dr. Ron Harper, who does a lot of neuroimaging research and basic neuroscience, has made tremendous contributions to our understanding of how sleep and sleep disorders affect the brain using functional MRI imaging. Dr. Jerome Siegel has done extensive research in the Semel Institute on basic underlying sleep physiology and disorders. And actually recently, every patient I see has asked me about, did I read the article that he wrote about hunter-gatherer tribes and doing actigraphy? And so it's constantly I'm having to stay on top of things. But my focus again is on clinical sleep medicine. So, when I can't sleep, or I'm sleepy, or I'm not rested, that's when they come to me. This is a very common problem, sleep disorders in general. If physicians go to the length of asking about them, roughly 60% of patients in a primary care clinic will complain of some sort of a sleep disorder. The most common complaint being of insomnia, about half of them. About a quarter report symptoms suggestive of sleep apnea. We'll talk about that. OSA stands for obstructive sleep apnea. And about 30% of patients report symptoms consistent with restless legs syndrome. And I'll touch on those as we move forward. I'm going to stop for a second and just talk about sleep disorder breathing, because this is an area that generates a lot of confusion for both practitioners and patients, and they kind of want to understand what's going on. Do I snore, and is that bad? And if I snore, and what's apnea, and when do I need to worry about it? So really, like most things in biology, there's a spectrum, and we have defined some cut points based on what we have identified as risk factors associated with potential pathology. Snoring by itself is tissue vibrating in the air passages when we sleep. Our muscles relax when we sleep, including the muscles in the back of the throat, what are referred to as the pharyngeal dilator muscles, and they partially collapse into the airway and they vibrate, and that creates a snore sound. If that doesn't bother the person who's snoring, doesn't bother anyone else, doesn't disrupt sleep, we don't worry about it. The next kind of level is snoring that interferes with sleep. So a person is snoring, they're having to work a little bit harder to get the air into the lungs, and they kind of wake themselves up. That can disrupt sleep, and it can make people feel bad and not feel fully rested. And the term for that has very well been called upper airway resistance syndrome or sleep-related breathing disorder. Then we start talking about obstructive sleep apnea or obstructive sleep apnea hypopnea syndrome. What we're talking about there is really occlusion or partial occlusion of the airway resulting in a drop in oxygen level or an arousal from sleep. And we have some specific criteria we use, and once you start falling into that category, based on the number of abnormal breathing events per hour, that can increase the risk of other health problems. Most strongly, that association has been linked with cardiovascular disease, increased risk of developing high blood pressure and aggravating cardiac comorbidities, coronary artery disease, heart rhythm problems, and congestive heart failure. There are other flavors of sleep-related breathing problems, central sleep apnea, where the brain is not kind of synchronized well and the person is not taking breaths normally during sleep. There's an entity we call complex sleep apnea, and we see this in patients who may have significant cardiac or pulmonary or neurologic comorbidities or medical problems that predispose to more disruption in this area. Some of you in the audience may have had a sleep test or have a family member who had a sleep test, and there's a lot of numbers that are thrown around and what number means what. I put this up there just so you know. The apnea-hypopnea index, if that number is greater than 15, 15 events per hour, that means that person is having an apnea or a hypopnea about 15 times per hour, you have sleep apnea. There's no question. No one debates that. There's some other terminology called the respiratory disturbance index, which has kind of come and gone through the years, as well as the respiratory disturbance index. If that number is greater than 15, it may mean you have apnea, but that's something that, depending on other health problems you may have or the extent of symptoms, it's a conversation with your healthcare provider of whether that warrants treatment. As far as epidemiology, how common is the problem? If you look at large populations and ask how many people have mild obstructive sleep apnea and the symptoms being non-restorative sleep, not feeling rested, and probably about 5 abnormal breathing events per hour is the cutoff we use, almost 20% of the population is going to meet that criteria, of the U.S. population. Now, does that mean everyone needs to be treated? That's a separate question. About 1 in 15 adults in the U.S. has moderate to severe sleep apnea. When we start talking about moderate to severe, we're talking about that even if there's not a lot of symptoms, that degree of apnea has been shown to increase the risk of other health problems progressing, namely high blood pressure and heart disease. The vast majority of people who have sleep apnea have no idea. Roughly 80% of people out there, based on U.S. population and risk factors for sleep apnea, are not aware that they have the problem and are not diagnosed. Interestingly, and I hear this all the time from a patient who's brought in because either during a medical procedure where they receive sedation or a bed partner complains, you stop breathing at night, sounds like you're choking, it scares the heck out of me. Patients saying, I don't know why I'm here. I'm here because so-and-so dragged me here. And they say, I know what sleep apnea is. I have a friend who has it. He's fallen asleep at lunch every day. He falls asleep driving his car. I don't have it. I don't have those symptoms. It's challenging because this is a challenging practice because there's not a strong correlation between the severity of apnea and the severity of symptoms. In my experience, mild sleep apnea, people who don't have a lot of abnormal breathing events, whose oxygen levels don't change that much, don't drop into a dangerous range, complain a lot. They may complain a lot of fatigue, sleep disruption, I'm not getting the rest I should from sleep. I have patients, and I saw literally one this morning and one yesterday, who were only there because their spouse dragged them in, and they've probably had severe sleep apnea for a decade or more, and I'm fine. I don't know why I'm here. I'm here just to satisfy my spouse. And so the symptoms don't strongly correlate with severity, which makes this challenging, which is why a majority of people are not diagnosed. So a little technical talk now. Physiologic changes during sleep. I went into sleep medicine. I was a neuroscience major, psychobiology, and as an undergrad, and always had a strong interest in neurology and neurosciences, and over time, kind of found that I liked a lot of things, and so pulmonary critical care was a good match, and then sleep was a good way to bring the neurology back into it. But what really kind of drives my interest was physiology, and what are the physiologic changes that occur. Sleep is a very unique physiologic state. And in addition to the neurologic changes, there's a number of changes that affect your breathing. In general, alveolar ventilation, how much air gets actually into the lungs, decreases because we take shallower breaths. There's a decrease in our tidal volume. That's due both to changes in position, going from standing upright to lying flat, supine, as well as kind of the down regulation of our overall muscle activity during sleep. There's a resultant decrease in our arterial oxygen levels and an increase in our carbon dioxide. Because we breathe more shallow, our oxygen drops a little bit and our carbon dioxide goes up a little bit. That's not a big deal if you're a healthy, normal individual. But if you have chronic heart disease or chronic lung disease, that could tip you over into a dangerous range. You're less responsive to low oxygen and to high carbon dioxide. And there's an increase in upper airway resistance. What we call the upper airway is composed of, from the nose down to what we call the extrathoracic trachea, the part of the windpipe that's outside of the chest. When we break that area down, I'll have some images to show you as well. We refer to the pharynx and the posterior oropharynx, which is the back of the throat and back behind the nose and behind the tongue and farther down. And the muscles that normally keep that area patent, open, relax during sleep, so they can partially collapse the airway, and that's what's happening during apnea, and I'll illustrate that. Generally in sleep, we don't use up as much oxygen. This is a decrease in FRC. This is, again, for our medical trainees, the terminology is there, but essentially because we breathe more shallow, the matching of our breath to our circulation can be more variable. So if you have an underlying chronic heart problem or a chronic lung problem, and how I put this very simply to our trainees is, if you don't sleep, if you have a breathing problem during the day, chances are you're having a worsening breathing problem when you go to sleep, is essentially what it comes down to. Okay. During sleep, sleep itself is dynamic. I took out some, I thought, extraneous slides about the history of sleep, and for the vast majority of human history, there's no true understanding of what sleep was from a technical perspective. It was it's often a topic of philosophical and psychological conjecture, but not. We didn't know a whole lot about what actually happened to the body when someone slept. It wasn't truly until the advent of EEGs in the 1930s, 40s, and then the development of an interest in sleep research in the 1950s and 60s, at the time when REM sleep was starting to be identified and people were starting to understand the difference, that we really started to understand what sleep was, and sleep wasn't just one thing, just the absence of wakefulness, but actually quite a dynamic process that's highly regulated. We break down sleep roughly to non-REM and REM sleep, and one of the ways, a simplistic way that oftentimes the sleep neurologist will describe the different states of consciousness is there's wake, where mind is awake and body is awake. There is non-REM sleep, where the mind is asleep and the body is asleep. And then there's REM sleep, where I'm using mind and brain as equivalents. I know that not always used as the same, but then there's REM sleep, where the brain is quite active and the body is relaxed. In non-REM sleep, which tends to occur in the first half of the night in greater proportion, it's a very stable state. There's high parasympathetic tone. The parasympathetic nervous system is the rest and digest system. And there can be some apnea and abnormal breathing during that time, but that's what most of us think about of simple kind of when we go to sleep. REM sleep, or rapid eye movement sleep, is when people tend to dream. It is a unique physiologic state, distinct from these other stages of sleep in a couple ways. One, there's much more autonomic dysregulation. There's activity in both the sympathetic and parasympathetic systems that vary through the course of the night. The breathing patterns can become a little bit more irregular. Oftentimes when people are transitioning from non-REM to REM sleep, there may be pauses in the heart rhythm. And actually the brain is using a lot more oxygen than it is at other stages of sleep, and it can sometimes exceed the oxygen consumption at wakefulness. The reason this is important is sleep disorders vary in their presentation and their manifestation depending on what part of sleep they affect. Sleep disordered breathing, in all of us, we're all more prone to have apnea or disrupted breathing from occlusion of our upper airway when we sleep on our back and when we're in REM sleep. So REM sleep tends to occur in the early morning hours. So oftentimes what people will tell me is I go to sleep fine, I'm sleeping okay, and then between that 3, 5 a.m. time, I wake up a bunch of times. I don't know what's waking me up, and it's really hard to get back to sleep. To me, that makes me think apnea. Well, everything makes me think apnea because it's so common, but that really makes me think, is it apnea? Because of the timing of these transitions in the sleep cycle. So what are we seeing? So this is a schematic often used to kind of describe what's happening with apnea. This is the uvula, which hangs from the roof of the mouth and is attached to the soft palate, also referred as the velum or the velopharynx. What happens if this part, when you sleep and if you're lying in a supine position, these muscles relax, they start to drop back. This is the tongue, and the tongue drops back, and it's actually the tongue blocking the air passage almost completely that causes oxygen levels to drop and triggers awakenings from sleep. And that's the primary kind of site of obstruction, the posterior oropharynx and just inferior, just below the velopharynx. What do we ask people when they come in and they think they may have sleep apnea? First thing I ask them is they snore. Not everyone who snores has sleep apnea. The vast majority of people who have sleep apnea snore. Some people who don't have bed partners don't know. And this is a genuine issue. A lot of people who don't have anyone observing their breathing or anyone to comment on this is not going to be aware of this necessarily. Sleep fragmentation, meaning I go to sleep and I wake up. Going to sleep and waking up multiple times a night and not being able to fall back to sleep can also be a symptom of apnea or another sleep disorder. So we certainly ask about that. Witnessed apnea, someone watching someone not being able to breathe, is a pretty strong indicator. Morning headaches can be a sign of low oxygen and high carbon dioxide over the night, which can contribute. There's some various scales. Daytime sleepiness, as I mentioned earlier, is not a great predictor, but there is something called the Epworth Sleepiness Scales, and kind of assesses an individual's tendency to fall asleep during various circumstances. And it's what we have. It's not great, but it's what we have. Nocturia, or waking up a lot at night to urinate, and orthopnea. I can't breathe, I get short of breath lying flat. Those are under-recognized symptoms of sleep apnea. I will have the most reluctant, curmudgeon-y husband dragged in by his wife who says he's fine, and the only thing he'll say is, I wake up 4 times a night to urinate. But that's because I just need to urinate. That has nothing to do with my breathing. I tell them that's an under-recognized symptom of sleep apnea. They usually don't believe me. We do the test. They have severe sleep apnea. We treat them with CPAP or some form of treatment. And sometimes, oftentimes most patients feel better. Some don't. If I really twist their arm and say, is anything better? Well, I'm not waking up so much to urinate. That sometimes is the improvement, and if that improves the quality of sleep and improves the daytime alertness and energy, then we've met our goals. If not, then we talk more about how to optimize treatment. Sleep position I mentioned, more likely to happen on your back. Work performance, certainly falling asleep on the computer, having to drink lots of caffeine is not normal. These are signs of sleep deprivation, and as we'll get to later, can actually propagate a cycle of inadequate and insufficient sleep. And certainly, long-term health risks don't matter a whole lot if you're falling asleep coming down the 405, the 10, or anywhere else. And I say that kind of casually, but it is a genuine and very real public health risk. If you think about what I just said, 80+% of people are not diagnosed. You think about what your average commercial truck driver looks like and the risk factors for sleep apnea. it's scary. It's quite scary. When I was in training, I trained in, did my fellowship in St. Louis, and it was at Washington University, big campus, so had a shuttle that went around, and I will tell you, my shuttle bus driver had it down. They were open the shuttle bus, fall asleep, everyone gets on, literally just sitting there asleep. Everyone's on the bus, up, close the shuttle, drive to the next stop, fall asleep, open it up, come again. And I know, because I see it, there's people who live their life that way. And it's scary, both for them and for people who have to share the road. Physical exam, the things that we look for, obesity is a major risk factor, but not the only one. Up to 1/3 of patients with sleep apnea are not obese. Okay, that's important to understand. One of the most under-recognized population is postmenopausal women. It's more common in men than women overall until after menopause. The numbers start to even out a little bit more, and it's due to hormonal changes we don't completely understand. Mammals airway class is just kind of a classification scheme developed by an anesthesiologist to kind of predict how difficult it would be to put a tube down the throat for prior to surgery to give anesthesia. It's a rough estimate. I'll kind of show you what that looks like. If someone has a very small lower jaw or retro position lower jaw, significant overbite, that can predispose just anatomically to having apnea. And neck circumference is something that has been looked at in men if your collar size is over 17, and women if it's over 16, that's going to be a risk factor for apnea as well. There is variations amongst ethnicities. There's a stronger relationship between sleep apnea and obesity. In Caucasian populations, there's less of that association in Asian populations, especially East Asian populations. For the same severity of apnea, people of East Asian descent tend to be less obese. So they tend to have apnea less related to obesity, which I think is quite interesting and makes, and we need to investigate further. As far as a test, if you think you have these symptoms, what do? You go see your doc. There's a couple different types of tests. One's called a split night polysomnogram, or a sleep study where you spend the night in the lab. And the others, which we also refer to as an attended study. There's also what we call an ambulatory study, or a home sleep test, which is getting to be used increasingly frequently these days. This is kind of what I refer to as a Mallampati airway class. When we instruct the medical residents on how to do this is not a very difficult exam to perform. Open your mouth, stick out your tongue, don't say ah. Just open your mouth and stick out your tongue. If you can't see anything, if all you see is tongue, which is the case sometimes, these classes, 3 and 4, are kind of higher risk for having sleep apnea. This is an old slide that needs to be updated, but it shows kind of all the hookup that is needed during a sleep study. We don't have this big box anymore, everything's wireless. But what we're looking at is leads on the head, the EEG, to look at brainwave activity. It's how we stage sleep. It's also ways to detect potential nocturnal seizures. We do a more advanced EEG in those circumstances. We look at eye leads to look at eye movements, which help us stage sleep, airflow through the nose and mouth, activity on the chin, the muscle activity. We have belts on the chest and abdomen to look at effort, oxygen on the pulse oxygen on the finger, and there's leads on the legs to look at muscle activity. Yes, people do sleep with all this on. That's the first question, yes. Over 90+% of the time, and one of our exceptional sleep technicians is in the audience, will tell you that probably 90+% of the time we're able to get enough sleep to make a diagnosis. It's a small fraction of people who don't sleep, but it does happen. What's used more commonly these days is the home sleep test, probably most accurately described as a home sleep apnea test, because that's all we're testing for. It's not looking at brain waves, it's looking at effort, flow, and oxygen. So really it just tells us it's probably good enough. If we think someone has sleep apnea, we can do a home sleep test, and that's probably good enough to give us the information we need. It sometimes misses milder cases because I don't know if you're a sleeper or not. You could lie potentially with this on awake the entire night, and I would have no idea, okay, because I'm not looking at whether or not you're asleep. There's variations of this. This is just another home sleep testing device by a different manufacturer. Depending on patient characteristics and what information we're interested in, we may choose, the specific device. We do have the capacity to do kind of the comprehensive sleep test at home, but one would imagine that number of leads, you sweat a little bit, something falls off, there's just data loss, and it's really not very useful. So you end up just getting a bunch of unusable information. The limitations of the home sleep test, again, may miss milder cases. It's not validated in patients with significant cardiopulmonary or neurologic comorbidities or diseases, heart failure, emphysema, COPD, stroke, neuromuscular disease, people with severe skeletal abnormalities or muscle weakness due to a muscular dystrophy. These are people that really need to come into the laboratory. These are the criteria for obstructive sleep apnea, just so anyone knows, because I put this up for everybody because we are entering an era where insurance companies are heavily involved in our treatment decisions, it seems. So there are certain criteria that we need to fulfill to get people treated. But again, this is the presence of these symptoms, which can be quite broad: disrupted sleep, not feeling rested, trouble focusing, trouble concentrating, a partner or anyone who's witnessed apnea as well, in addition to an objective finding. Before I said that number is greater than 15, you definitely have sleep apnea. That's everyone has consensus on that. That range of 5 to 15 abnormal breathing events per hour, there's some debate there whether that warrants treatment. That degree of apnea probably increases the risk of developing high blood pressure, probably about twofold versus someone who has no apnea. But I think we all are pretty much in agreement, we all being sleep specialists, that if you have symptoms or significant comorbidities, high blood pressure, heart disease, heart rhythm problems, and you're in that mild range, that warrants treatment, okay? Now, tons of squiggly lines. This is what we do when we get a sleep study. This is the report that comes out. And my goal is not to make you experts at reading this, but to show you things that are quite obvious, I believe. Up here, this is where we're looking at eye movements. Don't worry about it right now. These are the EEG leads. Don't worry about them. What I want you to focus on right now is what it says chest and abdomen. I'm not sure if everyone can read that, but these are those effort belts. So this is a person trying to breathe, okay? They're making effort. Up here are what we call the flow channels. And what you see is that there's a lot of flow and then ongoing effort, but then no flow. That's obstructive apnea. After that flow, you can see that the oxygen levels drop from, I think, the mid-90s, 90, 95%, down to as low as 79%. Abnormal is certainly less than 88%, we all agree. Less than 90 in most cases, people would say is abnormal. As this person finally, what stops the apnea? The person finally wakes up. You can just see this. These squiggly lines are a little bit different than the squiggly lines right next to them. Trust me, that person woke up. They also increased their respiratory effort. They had to work harder to breathe. That increase, that waking up and working harder to breathe, is associated with a stress response. The sympathetic nervous system, the fight or flight, what we talk about, whether it's a saber-toothed tiger, psychological stress, or apnea at night, your body is reacting in a similar fashion. Increase in blood pressure, increase in heart rate, increase in stress hormones. So this is happening, this is a 2-minute screen. So these are divided as 30 seconds, so this is 2 minutes. And you can see that during this 2-minute period, the oxygen level is only in the normal range very briefly, okay? So this person basically falls asleep. This low oxygen is from the event prior, wakes themselves up, falls back asleep, obstructs their airway, wakes up, falls back to sleep, oxygen wakes up, falls back to sleep. This is suffering, okay? You may not know it. You may not know it, but this is going to contribute to real long-term damage. This is a closer up picture just showing what a hypopnea is. It's not complete occlusion, but the same sort of idea. This person is now sleeping, it's the same patient, is now sleeping on their side. There's a little bit of a watermark. Apnea is a little bit better when you're on your side, but this person still continues to have it, still continues to have significant drops in oxygen levels into the 80s. Again, this is a 2-minute period. And really the oxygen levels are only normal briefly for a period of maybe 5 to 10 seconds. And this is just a closer up picture that shows the same sort of idea. If just to hit home, that this is effort without flow and drop in oxygen. Okay, what do we do? So the technician's sitting there doing this. If this is happening during the daytime, you're in the intensive care unit immediately. If this is going on for 2 minutes, your sats are in the 80s, you're rushing to the ICU. What's happening? What's going on? The X-rays, CT scans, figure it out. But this is probably happening in a huge number of patients every night when they go to sleep. So what do we do about this? Our sleep tech is alone, and then they put the person on CPAP. And CPAP is continuous positive airway pressure. It's a very blunt but effective instrument. We just deliver air pressure that prevents the throat from collapsing. We titrate it or increase and adjust settings until it's optimally treated. We come up with a pressure setting, and our goal is to make sure that the person is sleeping on their back, and in dream sleep that we can still treat the apnea, and this little R says they're in REM sleep, and you can kind of see that their eyes are moving, and they're on their back. This little watermark tells you're supine, and all the airflow channels are in line. Okay, and that's what we call effective treatment. Oxygen levels look great. All right. I have a couple more slides of this, and I just want to show this briefly. So that last one I showed, the pressure setting he needed was pretty high. It's best to show kind of a severe case, and I'll tell you those last slides were from a person who is a UCLA professor, or was when I saw him, about 6'4" and close to 300 pounds. So a big guy, he needed a lot of pressure. This is a postmenopausal petite female with a BMI, body mass index, less than 20. I show this because to illustrate what the sleep stage does and the risks that just transitioning from non-REM to REM sleep can and potentially increase the risk of apnea. You can see overall, this is a compressed screen. This is, I think, 5 minutes. Oxygen levels are pretty stable. There's some variability in the flow. It's not completely even the whole way through, but there's no clear apnea, but there's no drop in oxygen. Okay, so we don't call this a disordered breathing at all at this point. As the person is starting to transition to REM sleep, and you'll have to take my word for it in this compressed screen, we're starting to see apnea. So you're starting to see effort and no flow. And now you're starting to see oxygen levels drop. And they're dropping down to the 70s, which is abnormal. And then this is kind of the close-up 2-minute version. During this time, this person is trying to breathe, and for 81.7 seconds, there's no oxygen flowing. And their oxygen is going from 97%, 96, 97%, well in the normal range, down to 62, 63%. Okay? This is the range when the heart starts to have abnormal beats, can predispose to rhythm problems, and ultimately the person wakes up from that. And this is REM sleep, dream sleep for our classical fans there. What happens when you dream? So same thing, what does the technician do in these circumstances? We put the person on CPAP and adjust the pressure. This person on a pressure of 7 centimeters of water pressure, which is not a whole lot, apnea is all fixed. Oxygen levels are fine. There's a little bit of variability in airflow, but not bad. Person is effectively treated. Treatment options, roughly speaking, for sleep apnea, there's lifestyle modification, meaning lose weight. Easy to say, hard to do, especially hard to do if you're chronically sleep deprived. Positional therapy, sleep on your side. It's the first thing we tell everybody. Surgical treatments, there's a number of them. UPPP is called uvulopalatopharyngoplasty. There's another one, LAUP, laser-assisted uvuloplasty. Those are kind of falling out of favor. The outcomes have not been very good in regards to long-term success. Major surgery, what we call orthognathic surgery, maxillomandibular advancement, really breaking and repositioning the jaw, or a tracheostomy in very extreme cases, not something that anyone really wants to do, but has been done in very severe cases, are the surgical options. A lot of people ask about mouthpieces, or the Snorenomore or other things that are advertised commercially. In general, those can be effective, custom-made devices, and we have a dental sleep program at UCLA, and Dr. Bob Merrill, runs that program and trains dentists from all over about how to evaluate people with sleep disorders and sleep disordered breathing. the appliances can be quite effective and I think are probably underused. Positive airway pressure treatment, the CPAP, there's AutoPAP and other versions of this, is probably the most commonly used treatment. It's the one that we have the most data for. It's the one that's most effective. Hypoglossal nerve stimulation I mentioned because they're having radio ads of the implant that now, if you can't tolerate your CPAP, there's an actual implant, a hypoglossal nerve stimulator. It's an old technology applied to kind of a new application. It's essentially undergo a procedure after you're deemed an appropriate candidate and have this device that kind of looks like a pacemaker, goes under the skin, and you turn it on when you go to sleep, and it senses when you breathe, and it sends a stimulus to the nerve that goes to the tongue, causing the tongue to contract. When the tongue contracts, it shortens and moves forward, and that opens up the airway. It's actually, kind of sounds out there. It's been out there for about 3 years now, and there's pretty good safety data, and we are now offering this at UCLA. Interestingly, I just mentioned, when we talk about treatment, 1981 is when CPAP came around. So I certainly was around then, and some of us in the room certainly were as well. So it's not that long that we've had, kind of an effective treatment for this that was not surgery. I want to move on, but I just want to talk about, a lot of people heard about this, see the mask, see it on a TV show, or had a friend who do it, and just, I can't do that. It's going to be terrible. I got this from a blog a few years ago, and this is completely taken exactly from what the patient said, and he describes a CPAP journey for 4 months. He said it's been frustrating at times with mask leaks, nasal congestion. This is par for the course. This is the stuff that we address with most of our patients who are diagnosed with sleep apnea. And then, goes on to say that he realized that to really get the benefit, I got to stick with it. After that, describe what we hear often, that this has been a significant positive impact, that they don't wake up with headaches anymore, don't need to wake up to use the bathroom as much, less sleepy during the day, watching movies, happier and just full of life. Success, right? Right. I just mentioned that last part because apnea is not all that I deal with. I am a pulmonary sleep doc. It's the easiest thing. The harder things are what we're going to touch on now. I put this slide up again because how do dolphins and sea mammals sleep? They sleep half a brain at a time. I think that's cool. I wish I could do that. All right. I just want to touch on a couple other common sleep disorders. Restless leg syndrome, which has now been renamed Willis-Ekbom disease. Don't ask me why. Well, partly why is because it can affect the arms as well, and more accurately, restless limb syndrome. This is an interesting kind of disorder. Really, we don't need a sleep study to prove it. It's a complaint, a clinical complaint. I just can't get comfortable. My legs just can't get comfortable. People oftentimes have a hard time putting words on it. They just feel the need to move their legs around. Tends to get worse in the evenings during sedentary situations or as they're preparing to go to sleep. Tends to get better if you walk a little bit. Again, my training was as a pulmonary critical care doc, and then I did my sleep training. And when I first heard of this, I was like, "Come on, this is some BS. We just made this disease up to sell some drugs, right? I mean, what is this?" I will tell you, I have changed that perspective. I don't necessarily believe in always all the medications we use necessarily to treat it, but it can be a genuine phenomenon, and in people who it really disrupts sleep, suffer immensely from that sleep deprivation. I recall when I was in training, I had a young man who was nearly suicidal from the lack of sleep and just not being able to do anything about this. Ultimately, we were able to get him on effective treatment after a while, and it was life-altering. Periodic limb movements are what we see during the sleep study, and this is repetitive movements of the legs. And this is just some other things that people may have that's associated with it. A lot of people may have experienced restless legs at some point in their life. I know I have when I was going kind of through my growth spurt and as an adolescent. I didn't know what it was then, but I just couldn't get comfortable. I'd have to move my legs around, do a little ritual every night. Pregnant women, it's very common during pregnancy, and it may have something to do with relative iron deficiency in these states or growth. There has been some genetic association with genes that are involved in limb development. This is what we see during the sleep study. Previously I had you focus on kind of the flow channels. This is the EMG, the leg muscle activity monitor, and it's showing these intermittent bursts of activity. Every now and then that can wake someone up, and they may not know what wakes them up, similarly to a breathing problem. Same thing in a little bit more of a condensed screen. The leg movements are occurring quite frequently, and if this is waking someone up repeatedly, they may not wake up to consciousness every time. They may just experience this as waking up a fraction of the times, and just experience this as I'm not fully rested when I wake up in the mornings. The treatment, as with almost everything in medicine, lifestyle modification is number one. The first bullet that we all put up and never talk about because it's really hard to do, and we can't do it. It has to be the person who's dealing with it. Getting rid of caffeine, nicotine, alcohol, diphenhydramine, Benadryl, which is one of the most commonly used drugs, can aggravate restless legs. Serotonin reuptake inhibitors, a lot of the antidepressants can actually contribute to the leg movements. Whether they actually cause restless legs, probably less likely, but it can, some of these drugs do affect the frequency of these movements during sleep. Caffeine is a challenge because it's, as you know, our favorite drug and the one that we often use when we have not slept enough. And we often do see that cycle of inadequate sleep, fatigue, treatment with caffeine, contributing to insomnia, contributing to leg movement. I will tell you, when I tell people to try to cut back caffeine, the looks I get. I mean, you would have thought that I'm asking them to commit some horrible crime. And it's just like, are you kidding me? You're going to take away my caffeine, doc? But I think if things are bad enough, people are willing, and it's usually after they've gotten over the withdrawal. It can be quite life-altering if you kind of can step away from that cycle of what contributes to chronic insomnia, inadequate sleep, and self-medicating because of fatigue. As far as drugs, not a big fan. I'll just touch on them. These are ropinirole, pramipexole. You may hear these drugs called Requip or Mirapex. They have some neurological issues regarding augmentation where symptoms can get worse with ongoing treatment. Gabapentin is another one, often used to treat diabetic nerve pain. Neurontin's the other term, is commonly used. Benzodiazepines, things like clonazepam, Klonopin, Valium, and opioids are effective, but not really ones that we want to use a lot because the side effect profile, we're trying to get away from a lot of these benzodiazepine type drugs, especially given the adverse safety profile as people get older and their effects on balance, potentially in memory. Lastly, in the last few minutes, and we'll open up for questions, I just want to touch base on insomnia. Insomnia is challenging. That's the hardest thing for most of us sleep docs to handle. In the ICU, it's our sickest patient that takes up all our time. The person who's got severe multiple organ system failure, on dialysis, on a ventilator, and very sick, and really that's the person who requires the most time for us in the intensive care unit. In the office, it's the insomnia patient. The severe sleep apnea patient, from my perspective, is easy to fix. I got a machine, I got a setting, put it on, get you to use it. I can convince you, and then we can tinker with it, get it to work for you. You're treated. The insomnia is what's challenging, and we'll touch on why. Because insomnia has to do with everything. It has to do with everything. And it's really only recently, and this was an NIH consensus statement in 2005, about really approaching it as a genuine independent problem, not always as a consequence of some other problem. It tends to really require a high proportion of our healthcare resources. You can sell a lot of drugs if you got the magic pill. It's going to put you to sleep, okay? And they do. It can significantly adverse affect quality of life, impair work cognitive performance, and in cases can be a symptom of or contribute to mood disorders, depression, and anxiety. Not to oversimplify things, I put the pointer down because this is literally what I do multiple times a day when I have the insomnia patient, is this. Mood disorders, sleep disorders. Cannot take them apart. If you don't sleep well, you tend to be more depressed and anxious. If you're depressed and anxious, you tend not to sleep well. Sometimes people who are depressed and anxious sleep or try to sleep to avoid dealing with the things that are contributing to depression and anxiety. So it really, again, they see me, they think I'm just a lung doc, so I'm just going to put a machine on their face and say goodbye. No, I think it's important to address that aspect too, if not with me, with someone who will take that seriously. I had to put the equation up because of where we are, and this is the most important equation in insomnia management. More time in bed does not equal more sleep. Okay, that is number one. When we approach the management of insomnia, we kind of categorize and break it down to predisposing, precipitating, and perpetuating factors. Predisposing factors, there's some people I see who, doc, I didn't sleep well since I was a baby. My parents told me I never slept well. No one in my family sleeps well, and I don't sleep well now. Maybe we will be able to categorize that better in the years to come, but for now, okay, we know about it. I don't know if I can do much about it. Second, precipitating factors, and this is important in some cases where the insomnia is largely generated by poor coping related to chronic or past or current stressors. And I will often ask some people, when did the insomnia start? People can sometimes identify a time period, a traumatic event, whether it's in their personal lives, professional lives, or whatever. Sometimes that may be helpful in people understanding when it started to process it and resolve it. Sometimes people aren't open to that, so we don't spend too much time on that section. What we really focus on is the perpetuating factors. And this is the things, simply put, the things that we as individuals do that get in the way of falling asleep. I'm going to say something here that I say to most of my patients with insomnia, which to me didn't occur to me to have to tell people this, but I've gotten feedback saying that no one ever told them this, and now that they know this, that things are going to be different. You don't have to try to sleep. You don't. It happens on its own. What we have to do is get ourselves out of the way. And this is in the absence of a, of course, if you have a significant breathing problem, a movement problem, I just showed you that can disrupt sleep. But if we're in the absence of a significant disrupting force of sleep, a breathing issue, a movement issue, an organic, so to speak, problem, oftentimes insomnia is just a propagation of maladaptive coping with what happened before. People sometimes think I'm a mind reader. I'm not. What I say is, let me guess. You go to bed, not falling asleep. You look at the clock. Look at the clock, you say, oh my gosh, it's midnight, not asleep yet. I gotta be up at 5. Okay. Try to fall asleep. Still not falling asleep. And you're trying really hard to fall asleep. Come on, fall asleep, fall asleep, fall asleep, just fall asleep. Okay, now what? It's 1 o'clock. Okay, I got 5. 4 hours. I got 4 hours. I can work on 4 hours. I'm trying to fall asleep. I got 3 hours. Oh my God, it's going to be terrible. And then, okay, I'm just going to get up and start baking. At this point, I'm just going to start baking. And that's what happens. And if that happens every night, and you believe that, and you prove it to yourself every night, guess what? It's a self-fulfilling prophecy, and you're just going to propagate this on and on and on. So how do we address this? Really, we try to, first, it's my responsibility to make sure nothing else is contributing to the insomnia that we would have to medically treat, so to speak. But after that, it's really talking about how to manage it, and that's really the term I use about insomnia. I'm not going to have a fix for you. I'm not going to have a pill. A lot of the patients I see, and because at the time they're seeing a sleep specialist, they've been on a bunch of pills. So, I tried Ambien, I tried Lunesta, someone gave me Trazodone, someone gave me Trazodone and this, and then I tried Xanax and Klonopin, and guess what? They all worked. They all worked for about a week or 2 weeks, and then they stopped, and they had to go up on doses, and then I freaked out about it, and I don't want to be Michael Jackson on propofol in the Ronald Reagan Hospital. And at the end of the talk, sometimes they're like, well, doc, what's the next drug you got for me? And that's where there needs to be a discussion, because I, in my practice, the analogy that I give is, if you got bad pneumonia and a cough, and you're coughing up and you're hacking, I'm going to give you a cough medicine, right? I want you to have some relief. I want you to not be coughing incessantly. But I'm also going to give you an antibiotic to treat the pneumonia. If you come to see me with insomnia and it's horrible and you're at wit's end and you are ready to kill somebody if you cannot get some sleep and you need something to knock you out, yes, I understand that experience. Trust me, I do. We will help you get some sleep, use a medication if needed, but part of that deal is we got to get the antibiotic in too. We got to treat the underlying cause, which may mean, some talking about feelings and stress responses and things that may be uncomfortable. Maybe you don't talk to me about it, but you need to talk to someone about it. Okay. I don't want to worry too much about the technical findings in insomnia. But as I mentioned, the things that we really talk about on the surface to improve insomnia and to improve your sleep health, really avoid caffeine after noon. I generally just say try to keep it in the morning. Just a quick show of hands, I want to ask a quick question. Which has more caffeine, a tall coffee from a Seattle-based coffee vendor, or a tall drip, let's call it, versus a shot of espresso? Which has more caffeine? Who says the drip coffee? Raise hands. Who says the espresso? Raise hands. Okay. I'll say it. A tall drip coffee is probably about 375 milligrams of caffeine. A shot of espresso, probably about 90. Okay? So if you want to cut back, get an Americano. Okay? If you're thinking about this, just so you have some sense. I bring that up because I didn't know that. You obviously have a much smaller volume when you're drinking espresso. You make it, a latte or whatever else. But you're drinking that drip, you're getting a lot more caffeine. That's the crack they're getting to you. So how do we address this? Really, the core of this is cognitive behavioral therapy, and that's really not necessarily, lie on the couch, tell me about your problems with your mom from childhood, and we'll try to process that. No, and the psychologists who I work with have told me very clearly when I talk to patients, tell them that's not what we do. If they've got core issues, they're going to leave here with core issues, but hopefully sleeping better. And really what the focus of cognitive behavioral therapy is to identify patterns or beliefs that predispose or contribute to insomnia and try to develop effective countermeasures. The simple stuff is, again, if you're not asleep, don't stay in bed. If you hit that 20-minute period or you get to that, I'm frustrated, I can't fall asleep, out of bed. We want to separate the bedroom from that experience of frustration, agitation, and irritation. That's the first step. What do you want to do? Don't get on the computer, start trying to do taxes, don't write email, don't try to be productive, which is what all of us do, I'm sure. If we have a night of insomnia, I know that's what I feel like doing. I don't have very much insomnia, so sleep deprived. It's not an issue for me. But we tend to try to be productive, and that's counterproductive to what we're trying to accomplish, which is go back to sleep. So dull, boring book, dim light. Real book, not an iPad or iReader. The light actually is stimulating. Sleep restriction therapy is something we use in severe cases where we actually use the fundamental physiology that sleep is a self-regulating process to our therapeutic benefit. So we deprive sleep as much as we can, hoping that it will occur during the times that we want it to occur. It's a pretty detailed, sometimes unpleasant treatment for a lot of patients when they're first starting, but it can be quite effective. And then other things that are probably effective are biofeedback, yoga, tai chi, mind-body relaxation. I'm focusing on what we know from a Western medicine perspective, that is not to exclude the wealth of data in other areas of medicine that have dealt with this chronically. But it is, there are probably other techniques. I think I want to stop there to leave time for questions. And certainly there will be several. There's things I didn't get time to talk about, including how melatonin affects us and our 24-hour cycles and our circadian rhythms, which are all intimately tied to treating any disorder or promoting healthy sleep. But I'm happy to take those in the form of questions, and I'll stop right there. All right. Thanks. Thank you.
Question from that.
Yeah.
I know you kind of touched on this briefly, but genetics is the new buzzword in medicine. I'm sure you've been getting a lot of questions about that. There's a lot of people here that do have that thing that says, my family has it, my grandfather had it, and now with genetic testing coming out, have you heard anything recent about some of the genetic issues that might be related to some of these insomnia-specific disorders?
So the question was about genetics and insomnia. It is an area of active research. It is not yet to the time where I'm ordering it as a routine test or...
For instance, MAOA, MAOB. Those epinephrine related to epinephrine. You could, in my family, we both have, all of us have single nucleotide.
Some polymorphism variation on those specific
You
elements.
can't
Yeah.
get rid of epinephrine, meaning the adrenal,
Right.
which could impede
Which could, absolutely.
and does.
But we it's just not at the level to where I can order a test on someone. It's at a research level. And I think, and I very quickly touched on the extensive research that's being done here. So there's a lot of people in this room who probably know a lot more about basic neurophysiology in regards to sleep-wake regulation than I do. Ultimately, I'm a pragmatist because I have to do with the tools I have, and I don't have a tool for that yet. And that often ends up being a counter measure or a sedative. Of the people who have chronic insomnia, in the absence of significant comorbid other sleep disorders, there's probably, we estimate, on the order of 5 to 10% who have some sort of genuine disorder that does not allow them to sleep. And those people probably, at this stage, require treatment with some sort of a sleep aid, whether that drug is Ambien, Lunesta, GABA type stuff, or whether it's a different class of drugs. There's a whole list of drugs that have been used for sleep, but that is the tool we have at this point. That's not behavioral. But a very good question. I put this up because there is the entity of fatal familial insomnia, which is genetically associated, thankfully very rare. It's a kind of a prion disease, and we don't see it. It's not common, extraordinarily rare. But you know, narcolepsy, there have certainly been specific genes identified and the pathways involved regarding orexin or hypocretin deficiency, and we're starting to make some progress there. One of the new pharmaceutical treatments for insomnia that's advertised heavily now, suvorexant, was actually developed as an antagonist to orexin hypocretin. So those are wake-promoting neurotransmitters. By blocking them, you induce sleep. And so they've been developed and now marketed as a new class of sleep drugs, and they're heavily advertised on television.
Yeah, our family isn't a big drug fan either.
Yeah.
We also react badly to drugs of all kinds, so maybe some other people
Yeah.
as well.
One of your slides said that apnea worsens over time. Does it worsen? Does it continue to worsen if treated with CPAP?
That's a very good question. I don't think we have tons of evidence about that. When I say worsens over time, if I did sleep studies on everybody in their 20s, 30s, 40s, 50s onwards, and I practice in Santa Monica, so 90 is not old. As we age, more likely to detect it. We're going to probably pick it up. The question becomes, if you're 90 years old and have sleep apnea, well, you're 90 years old. So that alone, you made it to, you've cleared a lot of hurdles. Is sleep apnea a problem there? Is it part of is it normal at that time? I don't think we know enough there. If I'm seeing someone, it's because they have a complaint, and we talk about it. Now, treatment with CPAP, interestingly, I don't think would necessarily change the clinical course. I don't think we have enough data to know that for sure. But it's again, an effective treatment, not a cure. Yeah. Go ahead.
Can a CPAP machine cure apnea? My husband's been using one for 8 years, and
Right.
can he go back and get another sleep?
So it's a treatment. It's not a cure. It is like I said, it's a very blunt but effective treatment.
It's effective.
I mean, he took 1981, he reversed the flow on a vacuum cleaner. I mean, that's where it came from. It was just applying pressure to keep the throat open. So very effective. It's more sophisticated now. They have adjusting machines and things that, you know, can certainly more closely match a person's breathing pattern. So it's more comfortable, but it's not curative. If you take it off, wait a couple days, do the sleep study again, in all likelihood, if the factors that predisposed him to having apnea are not gone, then they're probably not gone. Yeah, sorry, in the back, just.
take kind of stimulant drugs like Adderall or Ritalin, that type of thing, is there any way if they do need to take it to manage it to where it's not so effective on sleep patterns?
So the question was about children and being on stimulants for presumably ADD or ADHD or attention issues. I'm not a pediatrician. I have a couple comments though as a sleep doc. Kids do get sleep apnea, obstructive sleep apnea, not for the same reasons that adults do. Although adolescents now, with obesity being such an issue, sometimes pre-adolescents unfortunately are having more of an adult type of apnea where it's fat and things like that obstructing the airway. More commonly in children, it's the tonsils. And it's kids around 2 years old and they just got big tonsils and you cut them, you do a sleep study, you cut them out, it's cured. Children with sleep apnea don't present as sleepy. They're not kind of sleepy kids. They tend to be hyperactive. So that question itself, in my mind and in my experience, has raised a number of other questions about the diagnosis and what things can potentially contribute to it. As far as the long-term management of stimulants, I think that's a very complex question. What drugs to use, when, how to minimize the potential for tolerance. In my practice, I'm dealing mostly with adults. We still do things like drug holidays, and our discussions are we need to be very cognizant about how to use the lowest effective dose, and when we can use other non-pharmacologic means to manage the symptoms.
You talked about electronics. If you are lying there for a while, what is your perspective on electronics just before bed and check?
Bad. Yeah, I mean, I say that, but then I have some patients who'll say, well, or friends, you go to the dinner party, oh, what do you do? You're a doc? Okay, I'm a pulmonary doc, nobody cares. Sleep doc? Oh yeah, well, I got 25 questions, right? So then the question becomes, what do you think about? What's your opinion on? I read something that was not good to be on my iPad before bed. Well, I read my iPad every night before bed. And do you have a problem sleeping? No. Then I can't complain. But if you have insomnia and you're telling me you have a problem sleeping, well, let's start getting those things away. And the idea is the light. The light is activating, and every now and then, something on the computer or television is actually interesting and grabs your attention, and you're engaged. So these are counter to what we're trying to do. We're trying to get rid of things, decrease the stimuli, dark, quiet, cool, promote sleep. It's also the time when sometimes unresolved conflicts come up. No kids to deal with, no work to deal with, no email. All the distractions are gone, and you're left with your thoughts, and that can be quite difficult for some people.
Is there such a thing as snoring only when you're really tired or you're really sleeping, like deep sleep?
I'm sure there can be, yeah, absolutely, but most of the time it's the degree of muscle relaxation. So on any given night, if someone drinks a little bit more alcohol, they may be more prone to obstructing their airway. If they're extremely fatigued, potentially that and have been very sleep deprived, maybe they go into REM sleep earlier. Maybe you notice something that you may not have noticed previously just because of the timing of sleep. It's possible. I'm not going to say no.
Okay. So you recommend that if you can't sleep for 20 minutes, you should get out of bed and go someplace else and read a book?
That's general. The question is about what to do when you can't fall asleep. Yeah, that's a general recommendation.
So if you start to get sleepy, should you go back to bed or should you just fall asleep?
Go back to bed.
Oh.
Go back to bed. And so the idea being that if you do this consistently, and the other part of this that I often counsel people is we have to institute some structure to a very unstructured problem. You can't fall asleep, you stay in bed too long, you may stay in bed later in the morning, and these are the things that aggravate the insomnia. So the kind of general recommendation is wake up at the same time every day, get as much light as you can. Light will actually inhibit melatonin secretion and tells us our bodies to wake up. And by doing that, setting the anchor at the wake up time every day, we hopefully start to get some regulation. So the night that you don't sleep well, I don't care if you slept 2 hours, 3 hours, 6 hours, you wake up at the same time. That night that you slept poorly, that following day you're going to be very tired. And if we say no naps, and I give a little caveat, if you have to really nap, siesta time for an hour. Early afternoon, 1 to 4 p.m., no longer than an hour. If you really slept only an hour the night before and suffering. And then hopefully that subsequent night, you'll fall asleep more easily. The idea being, if you start training and conditioning your body not to stay in bed and kind of ruminate about things that either the consequences of sleep deprivation or what may be happening because of the lack of sleep, that pattern over time will get you to where you're falling asleep more quickly. The bed is less of a stressor and waking up more consistently.
One last
Related to that? Oh, I just want to follow up on that, because I had heard that you really can't make up sleep. In other words, if I slept poorly last night, maybe I can make it up tonight, but after that.
That's a very, the questions about making up sleep and sleep, that's a very interesting question, and it's in the books, and I'm fascinated by it because I have lots of sleep debt, and I don't know if I'm ever going to make it up. But I will tell you, after one night of sleep deprivation on the recovery night, typically you need 2 recovery nights, sometimes more. But on that first night of recovery sleep, your body gets a lot of slow wave sleep, a greater portion of slow wave sleep. Slow wave sleep is when there's a lot of coordination of hormonal secretion. And it's a time when in young people or people who exercise extensively, they get more slow wave sleep. The second recovery night, you catch up on REM sleep. And so all these sleep stages, although we don't precisely understand the reasons each, we do know a lot about slow wave sleep, and again, people in the room probably know more about the neurologic underpinnings of some of these sleep and sleep disorders more than I do. But they're all important, and your body, if deprived of sleep overall or a specific stage of sleep, tries to recover, when given the opportunity. All right. Thank you very much for your time. Appreciate it.